Good morning, everyone. My case is a 4-month-old female infant. Her mother noticed bilateral cloudy cornea since birth. Her birth history was she was born by C-section at 35 gestational age due to fetal distress. Her birth weight was 1 kilogram, and she got an ICU admission. Antenatal history was unremarkable. Family history, they had a history of cloudy cornea and parents were not consanguineous. As you can see in the family history, they had unilateral corneal opacity as her grandparent and her parent as well. So her visual acuity, both eyes not fixing or following, and only blinks to bright light. In the right eye, there is superior corneal opacity. Inferiorly, the cornea is clear, however. Iris can be seen inferiorly and the AC was deep. Left eye had total corneal opacity and we cannot see any AC details. No fundus view due to the cloudy cornea. So on examination, her IOP was 5 in the right eye, 7 in the left. Horizontal corneal diameter was 11 millimeters. Axial length 18.19 in the right eye, 18.71 in the left eye. And I'm going to show you the UBM pictures in a while. The clinical picture is, as you can see, bilateral corneal opacities. The UBM picture showed iridocorneal adhesions in both eyes. The B-scan showed flat retina in both eyes. So my question is, what is the best surgical approach for this patient?
First of all, I suppose the diagnosis, what do you think? It's Peters anomaly?
Yes.
And it's one of the good Peters anomalies that the lens isn't attached to the back of the cornea. And you probably could, I think, is the right eye, is the axis clear in the right eye or is it involved? The visual axis?
Yeah.
It is involved?
No, it's not.
No, so the right eye you might be able to leave alone at the moment. So the left eye then is a question of you've got to do something about it and you've got to do something soon because it'll become amblyopic. And so the only treatment you can is a full thickness corneal graft in the left eye.
I don't hear you very well, sorry. I don't hear what you're saying.
I mean, the other thing you could do on the left eye, you could do an optical iridectomy, but I'm not sure. It depends on how dense it is. But the option I think you'll have to do is to do a corneal transplant.
So I have, what about if the pupil is not clear? So if this opacity including the pupil and it's only clear inferiorly, what is the best approach?
Well,
you will do iridectomy in this eye, or?
You could do an iridectomy, but that's what I'm saying. It depends on how dense the opacity is. I mean, the right eye, I think you'll get away with doing nothing at the moment because there's a very likely chance the vision will develop. But the left eye looks pretty cloudy to me. And I'd say you might end up having to consider a corneal graft here, which with all the issues of having to do it and all the problems that arise with the corneal grafting. And the idea, if you do a graft, the success here in this eye would be determined by if you can keep the lens in the eye. As long as the child doesn't if it becomes aphakic, your prognosis gets a lot poorer. So that's the challenge in the corneal graft here, is to keep the child's natural lens in its eye. And once you take off that cornea, it's a frightening situation because the whole iris diaphragm, I've done many of these, it comes really forward. And so you've got to soften the eye with pharyngeal ring, with IV mannitol and good anesthesia, hyperventilation anesthesia. And then obviously all the things about managing the graft afterwards, managing the sutures, which is a critical period, taking them out at about 4 weeks and so on. And then obviously patching and so on.
How old was this child? I missed
4
that.
4 months.
4 months. I mean, if there's room for optical iridectomy, that would be, preferred. I think optical iridectomy is underutilized. But if there's no clarity there in that cornea in the left eye, and there's no lens adhesion to the cornea, you could consider keratoplasty, but you really have to educate the family with what is involved with that. And even in the best case scenario, the vision is really going to be poor in that eye. I mean, it's not going to be a good seeing eye. And as Mr. O'Keefe was alluding to, when you open the box of doing penetrating keratoplasty on that eye, you're opening a box that's going to have this child having multiple exams under anesthesia, risk for infection, rejection. It's really a huge undertaking that everyone has to understand what they're getting into before opening that box.
Navigational vision back.
I mean, if it's bilateral, I think there's no question.
Yeah.
Okay, about doing an eye. But if, he's asymmetric. I really don't have a good sense of that right eye, if it's significant or not. But let's say that it's not significant. Let's say the right eye was normal.
Yeah.
I would really hesitate in a unilateral case.
Well, as you say, you've got to really talk to the parents, give them all the pros and cons of what it entails and so on, and you've got to be prepared to look after this kid's eye intensively for quite a while.
You know, the intensity of the follow-up that is going to be required versus not doing anything, just that intensity of follow-up is a big change in that child's life. Yeah.
Well, that's excellent discussion. Can we ask for thank you, Dr. Ayman.